Welcome everyone. My name is Dr. Gary Severance with Henry Schein, and I will be your moderator for tonight. I'm very excited to welcome Dr. Stephanie Tran, a practicing endodontist and a renowned speaker. She will review the importance of CBCT imaging in assessing and treating root canals, fractures, cracked teeth, and more. Before we get started, I would like to take a moment to go over some housekeeping. If you have a question, please type it in the box labeled "Have a Question" on the right side of your screen, and we will answer all of them that we can at the end of the program. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. That's it for the start. Dr. Tran, welcome and congratulations on your recent engagement. That's wonderful. Hope you have some pictures during your program. And thank you for being with us tonight. I'll pass it over to you now.
Thank you so much, Dr. Severance, and thank you everyone for joining me tonight. It's a little bit later here on the East Coast, so I really appreciate all of my East Coast colleagues, but we set it up at this time, so hopefully a lot of West Coast colleagues can join in tonight too. And thank you, as always, to the Henry Schein team, Henry Schein Dental, for having me again as a webinar and lecturer. For everyone who's interested, today is one of quite a few CBCT lectures I've done before. If you want to learn a little bit more, you can definitely contact Henry Schein for some of my other previous webinars, many of which may be available on demand. So let's get started. Okay, so today what I'm going to be discussing is how I CBCT, and especially how CBCTs can be extremely helpful and how they're used in the general practice. So I'm Dr. Stephanie Tran, and I'm an endodontist. However, I did practice previously as a general dentist, and there are many key features about CBCTs that all practitioners should know about using the technology and how to read it. This is my disclosure slide. Thank you again for Henry Schein, to Henry Schein for having me tonight. So today we're going to be discussing kind of the main key features about CBCTs and when it's important to use them in, including in general practice when trying to better diagnose and treatment plan for endodontic treatment. So we're going to be discussing what are the key indicators for when a CBCT is helpful and when it's actually more advantageous than 2D radiography alone. I'm going to explain the top tips for how to review a scan, including how to understand all of the information, how to read the scans better, and how to understand the morphology of both the teeth and their surrounding structures. And I'm also going to be explaining the key factors to consider when determining case difficulty and knowing when it may be too difficult and when it's best to refer. Now, a lot of these key points are going to be the broad top tips or top features about CBCT to keep in mind, including in general practice. If you want to learn a little bit more or go in more depth, check out some of my previous CBCT lectures where I go into the specifics on each factor about CBCTs, including exactly all the indications when it should be used in endodontics and what it should be the modality of choice, how exactly to read all aspects of the CBCT, and much more. So definitely contact Henry Schein if you are interested in learning more. So a little bit about me. I'm actually originally a California girl. I was raised in Cupertino, California, and I moved to New York City for work and to practice endodontics. I went to University Pacific, both the undergrad and the dental school, where I completed their 2+3 accelerated program, after which I completed my GPR at Stony Brook here in New York. After both dental school and my general practice residency program, those were what really fueled my love and desire to practice comprehensive dentistry and especially restorative dentistry. So I practiced as a general dentist for a few years, but then I realized that while I definitely love restorative dentistry and general practice, my true passion was in endodontics. So I went on to complete my endodontics residency at University of Tennessee, and I now practice in New York City and the Hamptons, where I have an endodontic concierge practice. And I practice very closely with quite a few restorative and aesthetic cosmetic practices. So one of the things I'm definitely passionate about is endodontic education. And not only do I provide that here with Henry Schein, but if you are interested in learning a little bit more about endodontic education, top tips about endodontics, you can check out my Instagram at Her Holiness the Pole. There, you can tell I'm a big fan of puns, memes, but most importantly about endodontic education. Lately, I've been posting quite a few reels and videos about top tips, all aspects of endodontics, including diagnosis, how to do restoratively driven accesses, how to do restoratively driven treatment, instrumentation, and much more. So definitely check out my Instagram if you want to learn a little bit more. And that's where I post about all of my upcoming lectures, including those with Henry Schein. So when it comes to CBCT, we want to definitely understand what are the main indications to use it and when it should be the modality of choice. The way we know that is through the position paper by the AAE and the AAOMR, which does discuss line by line all the indications. I'll be discussing some of them in this lecture, but one of the first things we want to keep in mind is that we don't use CBCTs necessarily for every single detail. It should not be used routinely for endodontic diagnosis or for pure screening purposes. However, through this lecture, I will be discussing what are the main indications and what are its main advantages over two-dimensional radiography. We definitely still want to follow the ALARA rule, but there are definitely certain situations where CBCT is much more helpful. For certain aspects of preoperative diagnosis and treatment planning, when we want to closely evaluate the anatomy of the canals, and especially when we need to make very, very accurate measurements. So in endodontics, as well as in the general practice, we know that there's many times we want to have a better view of exactly the measurements of all aspects of both the tooth and the bone. So for example, our surgery colleagues, when placing implants, they want to make very accurate measurements of both the angulation and the width and the depth of the bone that's available to place an implant. And the same goes for endodontics, where we can make very accurate measurements when planning out surgeries, when mapping out all the canals, as well as for looking at the specific widths of the canal system and the root forms. We know that CBCTs are actually extremely accurate for measurements. They're also really great for measuring the working lengths as well. Now, in addition to many of these findings in a CBCT, there are certain advantages that a CBCT has over 2D radiographs, especially when it comes to evaluating radiolucencies versus radioopacities. The reason is because for 2D radiographs, it does require a certain amount of bone loss prior to the periapical radiolucencies and other radiolucencies actually showing up on a 2D radiograph. There have been some discussions as to exactly how much bone loss has to occur before it happens. And one of the key factors is exactly how much cortical plate has been lost prior to the bone loss showing up on a 2D radiograph. Additionally, the 2D radiographs have other disadvantages because there's some compression of the structures. There's also, it will look either elongated or foreshortened, so there's going to be a lot of distortion. There can be certain artifacts or noise, especially when there's overlap of different anatomical structures. And all of this will cause it to be a little bit more difficult to see a radiolucency. There have been quite a few papers published in endodontics that have determined that CBCTs are definitely far superior when diagnosing periapical radiolucencies, that they will actually be more common to be commonly seen, and they might be missed on a 2D radiograph. This comes into play as an important topic because there are certain times we want to evaluate exactly where the bone loss and radiolucencies are, and we might not be adequately able to read them on a 2D radiograph. Another helpful aspect of CBCTs is that we're able to evaluate the vital structures far more closely and how they are in relation to the teeth. So for example, we can see the sinus and understand a lot more aspects of the sinus as we scroll through in a CBCT. whether you take a larger field of view for like surgical procedures or a smaller field of view in endodontics, we can see a lot of details about the sinus, about the width, about its proximity to the roots, and much more. These are factors we're not really able to do with 2D radiography. Now, because CBCTs tell us a lot more information, that also is like a double-edged sword. That means that there's a lot more information that we need to pay attention to in 3D radiography. So that's every aspect of the canal anatomy. The chamber itself, we want to look at the bone loss, both vertical and horizontal. We want to see how much tooth structure has been lost, so it can give us an idea about caries, radiolucencies, and radiopacities, and much more. And yes, sometimes it can show us fractures. For the canals themselves, we get a much better understanding about the anatomy itself, where it curves, where it exits, how large or small the canals are, how calcified they are, as well as how thin the root walls are. One of the things about seeing the canals on a CBCT is sometimes when you are reading CBCTs, especially in the beginning, where you're seeing how much information is seen, it's almost kind of daunting, because canals that looked almost easy, quote unquote, will actually be able to see all aspects of the curvatures. Keep in mind, canals are in 3 dimensions, so not only is it curving in one plane, it's often curving in multiple. And so knowing a lot more information also means that you can see a lot more about how difficult things can be. We can also see, especially for CBCTs, they have been really great at evaluating existing root canal treatment and evaluating all aspects of the surrounding structures of the teeth as well. Now, because there's so much information, there's a lot we need to pay attention to, including the PBL, the lamina dura, exact locations of bone loss, and exact locations of where the PDL might be widened. Keep in mind that radiolucencies, because they show up more on a 3D radiograph, a 3D CBCT, rather than a 2D radiograph, there's almost a bit of a false positive. Like you'll almost see more periapical radiolucencies if you're not careful at reading a CBCT. And we can also, though, see all aspects of the bone loss. So we can see where there's maybe bony perforations of the bone loss, where it may extend to, may actually involve other teeth, and much more. And when we're evaluating previous root canal treatment, we can also see exactly where the previous root canal treatment had issues. We can see where it starts and ends. We can see how much tooth structure is remaining and what kind of mishaps may have occurred. This is why when having a CBCT, it's very, very helpful to take a CBCT prior to considering a retreatment, because why are we doing a retreatment? We want to do a retreatment when existing root canal treatment can be redone. It can be revised. However, we also really want to know when it can't, when there are situations that a retreatment is not necessary. So this is another great reason to use a CBCT. Now, when we are using a CBCT, what are some of the ways and how exactly do we read it? So we know that a CBCT has a lot more helpful information. We know that it can show us a lot more aspects of the tooth and the anatomy and the existing treatment and the bone. But how do we actually read it? So I'm going to go over just kind of quickly about how to read it. A lot of this is not going to be in exact specifics, because some of it is going to be machine dependent or manufacturer dependent. Some of it is going to be dependent on the exact software and screens and exact software readers that you use and the software that you have, and then also what kind of CBCT you took. If you want to learn a little bit more about it, you definitely want to talk to your CBCT manufacturers for a lot of the specifics. So how do you even take a good CBCT for endodontics? Ideally, it's all about the field of view, because with endodontic treatment, we're dealing with much smaller structures. So unlike ortho, unlike surgery, we're not looking at the broad aspects of the bone. We want to look super, super, super fine detail aspects of the tooth, the canals, and even within the TBLs itself. So we're talking about microns. We're talking about under 100 microns preferably. So that requires a limited field of view. We want to keep in mind that the field of view is inversely related to the resolution. So the larger the field of view, the poorer the resolution. Like, so the fuzzier, the grainier it is. It's like comparing an HD picture of like intraoral photography compared to just a general point and shoot or like an iPhone 6. It's a lot grainier, the resolution is poor, you can't see as much detail. We want to see as much detail as possible in endodontics for better diagnosis and treatment planning. So we definitely want to take a smaller field of view and using the smaller voxel sizes as much as possible, but that's going to be something you need to check with your machine. Basically, we want to take the highest quality of information rather than a higher quantity of information. A larger field of view has a lot more information. Now, there are a lot of factors that affect the resolution itself as well. The machine will affect exactly how much fine detail you could take, so it's definitely important for you to check with your machine and manufacturer if it has a smaller field of view, at what level the smaller field of view is, what kind of voxel sizes it can get down to, the location on the patient. So basically, if there's a lot more anatomy in the way or a lot more anatomy absorbing and scattering the radiation, it's going to affect the resolution as well. But even down to the viewer, I have definitely seen major differences when using different software as well as the different computer screen. And you do have to manipulate the image as well to get the best view. It's just like any kind of photograph. You want to make sure you're checking different filters, like changing the contrast, making sure you're using smaller voxel sizes, that kind of thing. One of the things to do if you're taking a limited field of view to try to make sure you have a higher resolution is not only do you take the smallest field of view possible at the highest resolution possible, you can actually set the anatomy in a certain way. If you set the CBCT centered away from restorations, you can actually decrease the amount of artifacts in beam hardening. And that way you will have fewer artifacts that could possibly get in the way of your image. So additionally, when we're reading the CBCT, we want to make sure that you're actually reading it properly. So unlike the larger field of views for like surgery where you're doing full arch or full head, a lot of times the slices will not be centered on a tooth. For endodontics, we want to make sure that you're taking the smallest field of view, and then when you actually view the image, you want to be centered on the tooth in question. At the root in question, actually you often have to center all the accesses per root, not just per tooth, so that way it's along the long axis of the tooth. Then you want to be able to scroll through all these, through each plane and scroll through all the slices to evaluate every aspect of it. So we're looking at it in much more fine detail and at a much closer up view for endodontics than in surgery or orthodontics. So keep those things in mind. Centered on the tooth or the root and closer up, very fine detail, smallest field of view possible. Other things that we can do in endodontics that are a little bit different in how we use the CBCT is we often can take serial slices. So you can set up a section of that tooth, set your slice thickness, and then actually have the machine make the slices for you. So that way you can look at it all together and then compare where things change, where a canal might show up, where a canal stops, that kind of thing. Now, one of the most common questions I get in endodontics is, can we use the CBCT to visualize fractures and cracks? And the honest answer is, sometimes. It really depends. It depends on both the beam hardening artifacts, anatomical artifacts, and most importantly, on how wide the crack is itself. We want to keep in mind, it's all about the person making the diagnosis and reading the CBCT. It's not just about the machine itself. Of course, having a machine that can do the highest resolution possible and the smallest field of view and voxel sizes are going to be really helpful. But even the best machine is not going to show very, very fine hairline cracks, and that is for several reasons. One, the crack has to be wide enough. There has to be enough negative space in between the two pieces for the crack to even show up on a CBCT. Currently, the existing CBCTs cannot show all cracks. Additionally, many of the things about the tooth that may be associated with a crack, so existing restorations, existing root canal treatments, can unfortunately cause artifacts which are called beam hardening. So root filling materials and restorations will cause these beam hardening artifacts that kind of look like these striations. And additionally, all types of filling materials, because they are radiopaque, they will actually show very, very, very white on a CBCT. And because they are so white, they actually will look larger. The beam hardening will make them kind of flare out and have these little like striations, which are hard to see. It's hard to make sure what's a crack and what's just root filling material. And it's also difficult to differentiate levels of radiopacity. So we can see all the little beam hardening examples here. And then here we can compare very closely what root filling materials and restorative materials will look like in a CBCT. You can't really tell the difference in radio opacity, like whiteness of a post even versus gutta percha. We know on a 2D radiograph, such as in this two-dimensional radiograph in the upper right, that a post is going, because it's metallic, is going to be far more radiopaque than gutta percha. However, we can see in the corresponding CBCT image on the bottom that they both just look equally radiopaque. So these are some things to keep in mind, that reading a CBCT is not super easy. We want to make sure we're understanding how to read it and what are the best things, like the best settings and the best ways to read the CBCT and to take the CBCT to set ourselves up for success. Now, when we're making that diagnosis with a CBCT, another thing to keep in mind is that even the best machine in the world can only help you so much if you don't fully understand diagnosis clinically as well. So the main thing to keep in mind is that the diagnosis does need to be done in conjunction with clinical findings. So one of the running jokes in like a hospital, for example, is that the radiologist will often write at the bottom. They'll say that they think certain things are found, but they always write at the bottom to be correlated with clinical findings. And why is that? Because a CBCT does not make a diagnosis in and of itself. We will need to put it in conjunction with clinical findings. Everything needs to match. So what are some of the ways that we make those the diagnoses and have those clinical findings? We want to make sure we see all aspects of it. So we use high magnification, really good light. We transilluminate. We can use dye to look for fractures and caries. We also want to correlate it with the patient's symptoms. So anything that we think we see or we're trying to diagnose on a CBCT does need to be correlated with clinical findings and the patient's symptoms. This is why the patient interview is still an integral process of all aspects of dental diagnosis. So we're asking the patients about their symptoms of pain, how old or what kind of restorations may have been on there, what is the dental history, that kind of thing. And we also want to compare it to what the clinical findings that we see are. So the caries, the probing depths. If we're looking for bone loss, we're trying to also evaluate that in conjunction with the clinical attachment levels and pocket descriptions, as well as the typical periodontal evaluations like furcation involvement and mobility as well. If there's a sinus tract, we often want to trace it. So if we see that there's a fistula of sinus tract clinically, we want to place a piece of gutta percha, which is radiopaque, into the sinus tract, and that way we can trace its origins. And then we, of course, want to do endodontic diagnostic testing. That is a key feature of any kind of diagnosis, especially in conjunction with CBCT findings. So doing the full slew of diagnostic tests, including percussion, palpation, cold, bite, and etc. And that way we can make a better preoperative diagnosis. Because one of the key features of using a CBCT is that we want to take a CBCT when the diagnosis might not match with what we may be seeing on a 2D radiograph. So making that clinical diagnosis is going to help us know when to take a CBCT. So one of the times we always want to take a CBCT is when those symptoms don't match. So we can see in this 2D radiograph that there seems to be a periapical radiolucency, and in many ways it seems to be associated with the apex of the upper left central, so tooth number 9. So this patient, for example, presented to me with this finding. They had for a couple of years been monitored by their restorative dentist, and they had noticed that there's this periapical radiolucency, and they referred to endodontics for diagnosis. Now, one of the important things we did was to start off with the clinical evaluation and diagnostic testing, and we found that everything seemed to be testing vital, and there were normal periapical tissues, no percussion or palpation tenderness, as well as normal responses to cold. So a CBCT is recommended in this case, so we can see why there is a periapical radiolucency, if there is one, and where it's coming from. So we can see in this 3D scan that there is a radiolucency, but we can see it's actually slightly away from the apex, and it's a example of a non-odontogenic lesion. So that's why this patient was referred to have this lesion biopsied and evaluated, and it turns out it was a nasopalatine cyst. But that is why taking a CBCT is important to evaluate these findings and matching them in conjunction with the clinical findings. So in this case, it was a nasopalatine duct cyst. When we're using the CBCT in endodontics, we want to know when it's necessary to take a CBCT. I'm not going to go into all the exact indications for all aspects. A few of my previous CBCT lectures do go into a little bit more detail on that, but this is a really good summary of the main reasons when you should definitely take a CBCT, and helps us for understanding the case difficulty and evaluating when to refer. So what are some of the key times to refer if you're not absolutely certain about the finding? So having a CBCT is really great to understand a lot more information, but if we don't know exactly what we're looking at, it's definitely important to refer both to endodontics if it's for endodontic treatment, but also if there are some concerns, you can refer it to radiology for further evaluation as well. You also want to consider referring if the findings do not match the symptoms or cannot be supported by the symptoms. So we talked about how CBCTs can sometimes have false positives, but we want to make sure that anything that we may or may not see on a CBCT has to be supported with clinical findings and symptoms. And you also may want to consider referring if you cannot treat the findings adequately. One of the ways to understand whether or not you're able to treat it adequately and when something may be too difficult is to verify that against the AAE checklist. So the AAE has published a really good kind of checklist to go through all aspects of a case if you're trying to evaluate case difficulty. Now let's go over some cases that give really great examples of when CBCT has been really key in making better diagnosis, but it can also kind of show you why endodontic diagnosis and treatment planning is not necessarily as easy as it looks. The CBCT does show a lot of the hidden secrets, we might like to say, about the tooth itself. Now, one of the things we talked about is that a CBCT reveals periapical radiolucencies far better than 2D radiographs. We know it can show at least 30 to 40% more periapical radiolucencies than 2D, and it's often twice as sensitive as periapical x-rays. So we can see in this example here that this patient who I was diagnosing for basically for pain, we're making endodontic diagnosis. When taken a CBCT, we can note not only that widened apical PDL, but we can also see that thickening of the sinus mucosa right over that same tooth where the symptoms were localized, as well as widening and thickening of that sinus mucosa right over the area of the widened PDL. So that tells us that shows us how a CBCT can show the radiolucencies far better, and it can show corresponding findings as well. So after doing endodontic diagnosis, and we can pinpoint it to tooth number 15 in this case, we can see that the CBCT findings also match that there's that thickening right over the same tooth, right there, and that widened apical PDL. Additionally, CBCTs are very helpful when trying to make more complicated diagnosis and can reveal the presence of previously undiagnosed pathoses. So for example, in this case, the patient had pain in the upper left, different patient and a different tooth number 15. This patient did not have any obvious swelling or sinus tracts, no deep probing depths, and they didn't have any gross caries that were really obvious either. We were trying to differentiate where the pain was coming from and to verify it's not coming from tooth number 14. So we did diagnostic testing, and tooth number 15 was found to have severe percussion tenderness and some palpation tenderness. When taking a CBCT, we took it because I wanted to verify. So in this case, the tooth did not respond to cold, but there was also some tenderness in tooth number 14, and we wanted to verify that 14 was not the culprit. So CBCT was really helpful because we can see from the scan that as we scroll through these slices and make serial slices, that there's, again, widening of the sinus mucosa right over the same tooth. We can see thickening of that mucosa. We can see the apical radiolucencies specifically around there as well. And we can see that both in the distal buccal, especially the distal buccal and mesiobuccal apices, whereas we don't see quite as much radiolucency around tooth number 14. So that helped us confirm, these findings helped us confirm the diagnosis. So the diagnosis in this case was pulpal necrosis with symptomatic apical periodontitis, and this was the patient's, this matched the patient's chief concern. So we treated tooth number 15, and that was all thanks to CBCTs helping us identify all aspects of it. Another reason to take a CBCT is when the patient has pain. Again, if you have difficulties in identifying exactly which tooth it's coming from. Keep in mind that this should be associated with in situations where you're trying to look for a widened PDL or a thickening of the mucosa. So it has to be like related factors. You may or may not see a periapical radiolucency. It depends on if there's pulpal necrosis or severe apical periodontitis. So in this case, this patient had another example of pain that was a little bit difficult to diagnose. This patient presented with severe pain in the lower right. Again, no obvious signs of swelling, sinus tracts, or deep probing depths. In this case, the crown was intact, and there had been no caries associated with the tooth in the lower right, so tooth number 30. And then, unfortunately, because the patient was in so much pain, a lot of the teeth were testing with positive symptoms, so severe tenderness to percussion and palpation. And the patient was in so much pain that trying to make the clinical testing and the endodontic diagnostic testing was a little difficult. 30 did not respond to cold, but 31 also had inconclusive findings. So whenever there are inconclusive findings, we definitely want to take a CBCT. And so in this case, we took a CBCT to verify where there might be symptoms coming from, and we could see that there was specifically radiolucency associated at the apex of tooth number 30. And we can see where it's a widened PDL right at that apex. Additionally, we can see some other important findings. Like we said, we are looking for the canal anatomy as well. And we can note that the canal appears to be a single canal space for most of the mesial canal system. So like the mesiolingual and the mesiobuccal canals are joined in a common space. That's important to note so that you don't necessarily go hunting for a second mesial canal unnecessarily. And it also means that we we want to manage that mesial canal in a certain way. So we can see from the CBCT that's kind of like oval shaped, so we want to manage both aspects of it. And we can see upon treatment that matches the 3D findings. So additionally, we could see that it seems to actually split a little bit or have an apical delta at the end. And we can see, because of the contrast, that there is widening of that apical PDL and like a periapical radiolucency, but it wasn't obvious from the initial radiograph. So CBCT is very helpful in these kinds of situations. Additionally, we definitely want to consider using a CBCT when we're suspecting any kind of complex anatomy. So according to that AE and AOMR position paper, a CBCT should still be considered the imaging modality of choice when we're treating teeth that have really complex anatomy. So one of those situations is, for example, a C-shaped canal system. So C-shaped canal systems are especially common in lower second molars and are a little bit more difficult to manage because the canals often join and separate at multiple levels. Now, this case was particularly interesting because this patient had actually seen 2 other endodontists prior to seeing me. And the reason was because they had this large periapical radiolucency that travels up the side of the tooth. So it's one of that like typical J-shaped lesion kind of presentations. This patient saw endodontists, and different ones gave the patient different responses. Some were concerned that there may be a fracture or some sort of perio-endo lesions. And this patient had a sinus tract, so they definitely had a chronic apical abscess. So a sinus tract along with this J-shaped lesion made it very much a concern. Additionally, this patient had a severely lingually tilted second molar. So what we are looking at is you're actually looking at that second molar from the lingual. So it's pointed, it's tilted so lingually, it's almost like horizontal, and you're looking at it, and we can see that therefore the patient has really odd occlusion on this second molar. When it has such odd occlusion, when it has this really weird presentation of a radiolucency, there were definitely some concerns about a fracture. We wanted to take a CBCT to try to rule out a fracture. So a CBCT was taken. We can definitely appreciate how complex the canal system is. So the canals, they join and separate at different levels, which is very common of C-shaped canal systems. We can see that radiolucency extends up the side of the tooth, which is definitely a concern for either a perio-endo lesion, which could easily happen with a tooth with such unusual occlusion. And we can see that C-shaped system means that it's actually a little bit more complex to treat this tooth. So from a treatment management standpoint, it definitely is one of those situations where that complex anatomy may be a consideration to refer out and not be treated within general practice, because a C-shaped canal system has to be treated very delicately. We can see from the scans and like scrolling through the scans that the root wall can be very thin, so delicate management and conservative treatment is definitely necessary. And because the canals, they kind of join in this ribbon sheath, it's actually harder to clean and harder to treat. Now, the good news is that this 3D scan did not reveal any obvious fractures. It did not seem to have it did not appear that the radiolucency extended completely up the side of the tooth, so it was not a clear perio-endo lesion. And this patient was particularly motivated to maintain this tooth. So after putting all the findings together and not being able to confirm any vertical root fractures or cracked tooth, split tooth issues, we proceeded with treatment. So this case was particularly interesting because the odd occlusion and that lingual tilt meant that I actually accessed from the straight buccal, actually just straight through the mesiobuccal cusp. And then I completed the endodontic treatment. So this was approximately January or February of this year. And then this patient had a 6-month recall, and there was a beautiful healing. So the sinus tract had resolved after the first appointment. So in this case, I did in 2 appointments to evaluate for healing. I had taken the CBCT during that first appointment to evaluate both the complex anatomy and evaluate for either perioendo issues or cracked tooth. Treated the tooth, and then by the second appointment, the sinus tract had resolved. And then now we can see the beautiful healing in that 6-month recall. So thanks to CBCT, we saved this patient from having this tooth extracted. Additionally, you definitely want to take a CBCT when we have any kind of concerns about severe calcifications within the tooth. So one of the things we use CBCT for, and why you might want to consider using a CBCT both in general practice and endodontic practice, is when we're trying to figure out if the tooth can even be treated at all, depending on how calcified the case is. So we can see from this case that there was a very large periapical radiolucency. We took a 3D scan because you can barely see the canal system in the 2D radiograph. So when we can barely see the canal like that, when you have pulp canal obliteration, we want to make sure if the canal is so calcified that it can't be treated. So we also want to evaluate the extent of the lesion. So this case is a great example of that. Upon scanning, the CBCT reveals that you can't even see the canal all the way up until the apical few millimeters. So that means it is so calcified, the canal is not even visible all the way down the tooth until the apical third. When it's that calcified, unfortunately, even with certain guides and stuff, it's very, very, very difficult to treat the canal system because you can't actually get into the canal until like 20 millimeters down the tooth, and that's too difficult. Additionally, taking the CBCT is very helpful to evaluate the extent of the bone loss, how much bone there is remaining, if the bone loss extends to the apex of other teeth, and if there's adequate bony collars, so like adequate alveolar bone structure around the tooth itself prior to attempting treatment. For these types of cases, if you were to just try to prep into it and access into it without a 3D scan, you might be digging for a very long time in very bad directions. More reasons that a CBCT can be very helpful in these types of situations. This is another case where it's another similar issue where the 2D radiograph did not show much of a canal system, and we can see here from the 3D scan that it is very difficult to see the canal at any point, indicating pulp canal obliteration. So when we're trying to evaluate for the canal system, you can see this is an example of how you center the scan. So when we talked about how when you're taking a scan, especially for endodontic treatment, diagnosis, and treatment planning, you need to center it on the tooth itself. You need to center all the axes along the long axis of the tooth and perpendicular to that axis for the other planes. And then you can scroll along each of these planes to see all aspects of the tooth, the root structure, and the canal system. So in this case, you can compare that the adjacent teeth have very clear canal systems, and this does not. It's so calcified that it's essentially obliterated all the way down the tooth. Another reason to take a CBCT as the imaging modality of choice is for any kind of resorptive defects. This is extremely important because only a CBCT can allow us to adequately evaluate the extent of the resorptive defect. For both internal and external resorption, you need to evaluate how much loss, how much resorption there is to decide whether or not it's treatable. So for example, in this case, this patient had been referred actually for a different reason. They had been referred because of caries on tooth number 2 that the restorative dentist was concerned was very close to the pulp. However, this patient had no symptoms, they reported no pain. And so when I was doing my initial evaluation, of course, you take a 2D periapical radiograph, and you can see kind of this like fuzziness in the cervical and chamber part of the pulp system. And then we can see you can see MO caries, it's kind of close to the pulp, but that we see this like kind of diffuse radiolucency right in the middle of the pulp chamber area. We tested it. And then whenever we see that kind of diffuse area, we definitely want to suspect possible external cervical invasive resorption, ECIR. So this is when a CBCT is key. We took a CBCT in this case, and we can actually see how extensive that resorptive defect is. So taking a CBCT not only helps us evaluate how severe the resorption is, it can also help us determine when to actually treat and when we cannot treat these resorptive defects. So anytime it's like a hither-say, past the hither-say class 2, that are very much concerned about whether or not it can be treated endodontically. So this saves the patient both invasive treatment, unnecessary numbers of procedures, and it saves you chair time as well. So this is why it's a key finding, or a key tool in evaluating these radiographic findings. We could see from these scans that I took, as well as scrolling through them, that ECIR was very extensive. It extended to the palatal area, extended down the cervical area, and so this let us know ahead of time that unfortunately this tooth was not able to be treated. This is another example of ECIR. Again, we can note that kind of diffuse radiolucency in that cervical region of the tooth, close to the pulp. Anytime we kind of see that fuzziness, we definitely want to take a CBCT to evaluate the extent of that ECIR. These are key findings so that we can evaluate whether or not it can be treated, if it can even be accessed, if the visualization may be too difficult, or if the tooth should be recommended for extraction instead. So as we scroll through it, we can see the exact extent and size of these resorptive defects, and we can evaluate how much root structure would be remaining if we were to try to go chase after these defects. So when we're using CBCTs, we also often want to use them for diagnosis of retreatments, because it can let us know whether or not a tooth can be retreated, where it needs to be retreated, like if there's a missed canal, if there are certain mishaps that are not visible, and whether or not this tooth should be retreated at all. Now, one of the things that we need to keep in mind, just like in that previous case, is that a J-shaped lesion, what seems to be a J-shaped lesion, is not necessarily pathognomonic for a vertical root fracture or a split tooth. What does that mean? It means that a radiolucency that appears to be kind of off-centered or coming up the side of the tooth does not automatically mean that the tooth is cracked. This is definitely a misunderstanding. So how do we read them instead? So we definitely want to put it all together with the findings, as well as the patient's symptoms, the 2D radiographic findings, and putting all that information together about whether or not it is actually a fracture. So for example, in this case, this was a good reason of why we want to take a CBCT. So this patient had some discomfort, some pain to biting and chewing. She said that her gums kind of felt swollen, and there was found to be a deep probing depth on the palatal. Now, a deep probing depth, just like we had discussed a J-shaped lesion, doesn't automatically mean a fracture at all times. We want to keep that in mind. Anytime there's a deep probing depth, that just means that there's some areas of bone loss. This, or a J-shaped lesion, can also just mean areas of bone loss. This can be due to either a very long-standing chronic apical periodontitis that goes up the side of the tooth, so a sulcular sinus tract. It can be due to multiple portals of exit along the tooth that can join and then make it look like it's J-shaped. And it can also be due to just where the canal exits. If it exits higher up the tooth, it may look a little bit more off-centered or J-shaped as well. But one of the reasons why we took a CBCT was to evaluate that bone loss and to evaluate what's going on in the mesiobuccal. So in this case, we can see that there is no root canal filling material in the mesiobuccal. What I'm trying to look for is whether or not that mesiobuccal root can even be treated. Was there just missed anatomy? Is it excessively calcified? Did the previous operator possibly ledge or cause some sort of issue that's not visible from the 2D radiograph? And then here we can see the CBCT was a key, showed key findings that may help us make the diagnosis. So we can see that there's the radiolucency surrounding the tooth, and it's actually far more severe than visible on the 2D radiograph. It extends on on both the buccal and lingual aspects of the palatal root. We can also see some possible radiolucent lines down the root as well. So there we can see that dark area, and that repeats in another aspect of that palatal root, and it's associated with that bone loss. So that tells us actually that the tooth was fractured. Another example of when we want to take a CBCT to evaluate for fractures, or at least to evaluate existing root canal treatment, is this one where this patient had presented again with pain, with some swelling around the tooth. And we can see that there's sort of this J-shaped lesion and some vertical bone loss around that mesiobuccal root as well. So we see that there's existing root canal filling material. It seems to be fairly centered. It even looks like they possibly had treated they definitely treated the mesiobuccal, but it's not really clear whether or not the MB2 had been treated. And this patient had some swelling around the tooth, so we definitely want to match all the clinical findings along with the radiographic findings. And we do see that there's vertical bone loss around that mesiobuccal root. And it appears to extend to the alveolar ridge with vertical bone loss and possibly some furcation involvement as well. So a CBCT was taken to evaluate the existing root filling material, as well as to evaluate whether or not this tooth could be retreated. And here we can see very obvious findings. We can see that there's severe that the bone loss is even more severe on the 3D scan. We can see that there's severe bone loss at the mid-root level along the furcation as well, in addition to the periapical radiolucency. So with such severe mid-root bone loss, as well as we can see that the root filling material is very close to the root wall. So there's very, very thin remaining root structure. So we can see the bone loss, the periapical radiolucency, that bone loss in the furcation area and mid-root level, and then most importantly, as we're scanning along it, that it's a very, very thin remaining root structure. That tells us, unfortunately, this tooth did have a vertical root fracture. In this case, most likely due to the lack of remaining root wall structure on the mesiobuccal root. So CBCTs are so helpful in determining whether or not it's worth even going into the tooth, and that can save you both chair time as well as the patient invasive treatment. So we can see here in existing root canal treatment, we want to always look at how much root structure is left. And the 2D radiograph may look very simple on one hand, but the 3D is what tells us all the secrets, such as the very, very thin remaining root structure on the mesiobuccal root. So again, this is another reason why it's very important to be cognizant of the remaining root structure, as well as how that we should be more conservative when treatment prior to doing endodontic treatment, because if the tooth doesn't have remaining tooth structure, then unfortunately it can't be retreated at all. So we can see here it's very, very thin. Now, again, we want to keep in mind that these thin areas or these J-shaped lesions have to be in line with existing clinical findings, and it's not an automatic decision just from a CBCT. So in this case, this is that previous case that I'd shown as examples of beam hardening. So this patient had a little bit of furcation bone loss and on the 3D radiograph, and also the periapical radiolucency and that mid-root kind of bone loss and furcation. There were definitely some concerns in this case of whether or not this tooth had a vertical root fracture. However, there weren't any deep probing depths and no sinus tracts, no other signs of a vertical root fracture. And this patient was very, very motivated to maintain this tooth. Additionally, this has to be in line with the restorative treatment planning. So in this case, the patient had a restorative dentist who really wanted to maintain this tooth as well as an adjacent tooth to an implant. Now, so in this case, because there were no frank signs of a vertical root fracture, Again, just because it has a J-shaped lesion does not mean it's automatically a root fracture. We had recommended for this tooth to be retreated. So sometimes we do want to give the tooth a chance when there are no obvious issues with redoing the endodontic treatment or revising the previous endodontic treatment. So we can see here that this tooth healed. So because upon retreatment there were no signs of a cracked tooth or vertical root fractures, retreatment was recommended, it was completed, and upon the 2-year recall, this patient had gotten their implant, but we can also note that they had full bone healing around this tooth after my endodontic retreatment. So if we can see that the 3D scan was helpful for making the diagnosis and making our decision to retreat this tooth, and it gave this patient the chance to maintain her tooth. So to summarize, in this lecture, I discussed how to recognize the key indicators for when a CBCT is far more helpful and it's advantageous over 2D radiographs, especially in general practice and endodontic practice. I reviewed the top tips for reviewing a scan, especially to understand the information on the CBCT and how to better read it and how to put that information in conjunction with clinical findings, and also how to identify key factors to consider when determining some of these cases that may be more advanced or may not be recommended for treatment or may be recommended to be referred to a specialist for treatment. I know that was a lot of information and we went into a lot of detail. I really want to thank everyone for joining me tonight. I want to thank Henry Schein again for having me take part in their webinar series and to lecture to everybody about my passion for endodontic education. Definitely feel free to contact me by email or by my Instagram at Her Holiness the Pulp, and you can check out future webinars, future lectures, and more endodontic education on my Instagram. Thank you again.
Wow, thank you, Dr. Tran.
That's a lot of info.
Wonderful.
Again, for
you can take a breath
attention.
now. We got a few minutes left. I'm going to jiggle we didn't get any questions because I think most people had it full screen, so they may not have been able to see that. I'll jiggle that, have a question here, and I think you'll get some. One of the questions that came in is about calcification. Are there any indications, or only when you take radiographs do you see the calcifications? Is there a pain associated with it? No,
not necessarily. So it depends on what kind of calcifications we're talking about. So pulp canal obliteration is often associated with some sort of canal irritation. So this can be as extensive as a history of trauma. We definitely often see pulp canal obliterations in trauma. We also see it when there's like long-standing caries or caries that's close to the pulp. So this is an important thing. A lot of times when we're doing restorative treatment and it's close to the pulp, just keep in mind that there is going to be calcification of the pulp canal system because of that irritation and inflammation. The pulp will react as a result to that irritation by calcifying and developing tertiary dentin and reactive dentin. Additionally, we will see that occurring in other like irritations. It can even be like perio treatment, orthodontic treatment, that kind of thing. But the main way we diagnose it is through radiographs, both 2-dimensional and 3-dimensional radiographs.
Great. Some more are coming in now. One wanted your email, so maybe you can just share your screen, your final one, and we'll address some of the other questions.
Sure.
On, say, a maxillary molar that has had root canal therapy, can the blackness between the roots be an artifact? I'm sorry?
It
says, can the blackness between the roots be an artifact? I guess the blackness on
like
the
furcation involvement?
It sounds, well, yeah, it says between the roots, so yeah, I would guess so. Mason, if you want to explain that a little bit more, maybe we can address it a little clearer. Dustin, do you have a minimum file size you will prep to? For an example, size 35 or larger?
No, I don't have a minimum because it's very much dependent on the canal system. So a 20-year-old palatal canal is going to have a different size than an 80-year-old MB2. So you want to prepare the canal system in a way that allows you to adequately clean the canal system, so adequately get irrigation solutions down the canal and instrument it. But it really depends on what the starting size was. So if it's a younger patient or a really large canal, the starting size may already be larger, so you may be finishing on a larger size.
I've seen on RCT, there can be a blackness that looks different than the radiolucency we see on a periapical or on a periapical lesions.
So it could mean that between the roots, I'm not sure if they meant like at the apex. So a CBCT will show periapical relucencies more than 2D radiograph, definitely. And that radiolucency may look a little bit different because it's much more obvious on a CBCT. Also, a PA X-ray, because of the overlapping anatomy as well as the cortical bone and what kind of bone structure there is, it's not necessarily going to show up the same way. I'm not really sure what they mean by if it's an artifact. Like, if it's not really so much of like an artifact the way beam hardening is, because those types of artifacts are due to radio opaque structures like root filling materials and restorative materials.
One thing, Mason, if you wanted to email us at webinars@henryschein.com, or if you had Dr. Tran's email, I'm sure if you wanted to include a photo, she'd be more than happy and we'd get it to her as well. Final question,
Yes.
We are just past the hour. Are you worried about detecting findings on a CBCT that you are not able to diagnose and treat?
That is a great question, actually. So yes, absolutely. So like I was talking about, a CBCT tells us so much more information. Not only do you have to be able to understand all that information, you need to know if that information can actually help or harm the patient in terms of whether or not it can be treated. So like whether or not treatment can be done or should be done. So for example, a CBCT will definitely show curvatures and like splitting canals and like possibly even lateral canals and that kind of thing far more. So it can be, like I was saying, a little bit daunting to know, oh my gosh, the anatomy is a lot more complex than you thought. Additionally, that if there are findings such as like severe bone loss or very complex situations, sometimes it means that the tooth cannot be treated. So kind of those situations of a retreatment where there's not enough tooth structure left, or the retreatment has something that's not able to be treated, like separate instrument that can't be removed, a perforation that's there that can't be repaired, ledging, or something where you cannot get back into the canal system. Those are all unfortunately really tough situations. If there is something that as a general practitioner you do not feel comfortable treating, then it's definitely one of those key things that we talked about, like reasons why you want to refer. You definitely want to talk to your friendly neighborhood endodontist and see if they can treat it. And if they can't, unfortunately, sometimes things can't be treated. It's like that patient of that case with the ECIR, the external cervical invasive resorption. It was a finding on the 2D. We noticed it on the 2D. It was super obvious on the 3D. And then the patient went from having, they thought they just needed a filling, to they actually need an extraction, or they're actually recommended for an extraction. It's really tough being the bearer of bad news in cases like that.
And in that case where you had the mesial had decay and the patient was in pain, was it because of the pain, because of the decay, or the resorption, or both, or you can't distinguish?
They actually didn't have pain. So they didn't have pain presenting. When I did the endodontic diagnostic testing, they did have hypersensitivity to cold. Now, the problem was that you're kind of in between a rock and a hard place. And I talked to the restorative dentist about this. They had mesial caries, but the caries were really close to the pulp. The restorative dentist, if they wanted to maintain this tooth, would have to really not only remove the decay, but also restore it, but then this tooth would flare up. If this tooth flares up, then endodontic treatment can't be done because of the external cervical invasive resorption that's so severe, it's not able to be treated. So then the patient definitely needed to have would definitely need to have an extraction at the time. But you can't just leave the patient with caries. So it's really between a rock and a hard place for that patient.
Yeah, but you did save additional cost to the patient coming right to the end result, yeah, in time.
Exactly. Mm-hmm.
Well, thank you so much, Dr. Tran, and thank you all for attending. We did record this, and you'll get an email with the recording within a week from the time. And then as you log out, there will be a survey. So if you had any suggestions for us, please put that in. Mason, you can ask your question or provide photos to us at webinars@henryschein.com or Dr. Tran's email address. I want to thank you again, Dr. Tran. Congratulations. We look forward to seeing you. And I think we should tell everyone you're working on a perioendo white paper or ebook with us that'll be out shortly. So thank you for supporting better dentistry in all ways. So wonderful. Thank you, everybody, for attending. Have a wonderful evening. Good night.
Have a good night. Thanks again. Thank you, Dr. Severance. Have a good night, everyone.